All right. Welcome back to NeuroClarity, the podcast that makes neurology crystal clear, one case at a time. I am your host, Onowori Victor, and today we are taking a deep dive into a spine MRI that holds the key to a vascular mystery. This case comes from a 52-year-old man with progressive leg weakness who suddenly couldn't walk one morning. Our case is derived, as usual, from Ching and Cheng's comprehensive review of clinical neurology. This episode is especially beginner friendly, and we are going to walk you through how to interpret spinal MRI, what different sequences mean, and how to recognize a life altering diagnosis that can be easily missed. That being said, let's get into it. Question 64. A 52-year-old man presents with progressive gait instability and lower extremity weakness over the past 3 months. He reports that last week he woke up one day and his legs couldn't move at all. His MRI is shown in figure 2.19 and a vascular anomaly is suspected. Which of the following is the most likely diagnosis? A. Epidural hematoma. B. Cavernous malformation. C. Spinal dural arteriovenous fistula. D. Venous angioma. And E. Spinal cord infarct. Let us take a look at our MRI. What do you think? Let's break down our question. We are told that we have a 52-year-old man with progressive gait instability for 3 months. He has gradual worsening weakness in both legs, and one morning he wakes up unable to move his legs. He has no history of trauma, no recent infection, and the progression has been insidious, but the last episode was sudden. His spine MRI shows an important clue. This is a STIR sequence. Let's decode it together. Before we jump into a diagnosis, let's actually talk about how to read an actual spine MRI, especially if you've never been taught the basics. Here's a cheat code. For T1 weighted MRI, fat appears bright and water appears dark. So, fat includes things like the bone marrow and the epidural fat, while water includes things like the CSF or the edema. T1 is great for anatomy, bone marrow, and structural detail. In fact, there's a cool mnemonic for this. T1 is tissue first. It shows the normal structures. For T2 weighted MRI, water, CSF, edema all appears bright. And most pathologies will light up on a T2 MRI. Mnemonic T2H2O. Lest we forget, fat appears white on T2. For the SCIR MRI, I like to call this the fat killer. SCIR is short for short tau inversion recovery, and it suppresses fat and emphasizes edema and inflammation. It is especially useful in spinal cord imaging. The mnemonic to remember this is SCIR suppresses the fat and illuminates the rash. So even though it's not a rash, anything edematous or inflamed will stand out clearly. How do we interpret our patient's MRI? We are looking at a STIR image, and here's what we notice. The spinal cord is swollen with diffuse bright signals, that is hyperintensities, over several vertebral levels. And if you look carefully, there are tiny black squiggly lines on the surface of the cord. These are flow voids and they are signs of abnormal blood vessels. The spinal cord is not supposed to appear white. There is no fluid in a healthy spinal cord. These two features, which includes the swollen and diffuse bright signal or the hyperintensities in several vertebral levels, coupled with the flow void, should raise a red flag. What is our diagnosis based on this MRI? Well, the correct answer is a spinal dural arteriovenous fistula. And let's break it down. What is a dural arteriovenous fistula? This is an abnormal connection between the dural artery and a vein, especially at nerve root sleeve, and it causes arterial blood to rush into veins, increasing venous pressure. This pressure leads to venous congestion called edema and progressive myelopathy. Who gets DAVF? usually men more than 50 years of age, and it is actually the most common spinal vascular malformation. The hallmark of this disease includes slowly progressive lower extremity weakness, gait disturbance, sensory loss, bowel or bladder dysfunction, and all these symptoms can have abrupt worsening, just like we saw in this patient. There is also a cool mnemonic for dural arteriovenous fistula symptoms, and they include weights, weakness, ataxia, gait trouble, and sensory loss. There are certain MRI features of DAVF, and they include 1. T2 or SCIR hyperintensities in the cord over multiple levels. 2. Cord swelling. 3. Perimedullary flow voids, which are black squiggly lines that are outside of the cord, and these are abnormal vessels. And lastly, it may extend over thoracolumbar regions, often below T6. What is the gold standard diagnosis for DAVF? Spinal angiography is the gold standard for diagnosis. The big question is, how do we treat? We treat by doing something we call endovascular embolization, or you could just surgically disconnect the fistula. Now, surgery has the highest success rate and the lowest rate of recurrence. The goal is to stop progression, and recovery actually depends on how long the cord has been compressed and how severe the symptoms are. These are differentials to rule out. 1. Epidural hematoma. Epidural hematoma occurs rapidly and usually occur after a trauma or anticoagulation. Cavernous malformation is another differential that you should rule out, and these are usually intramedullary, they are well circumscribed, and they may bleed. Venous angiomas, on the other hand, are rare in the spinal cord and are usually not symptomatic. Spinal cord infarcts occur very suddenly, and they typically present with a pencil like central cord signal and not the long segment seen here. This has been a very long one, and here are some key learning points and some mnemonics to stick it in. To remember DAVF, that is dural arteriovenous fistula, the mnemonic is David. Dural arteriovenous congestion is insidious in onset and disabling over time. If you see a middle-aged man with gradual myelopathy, a T2 or STIR bright cord, and flow voids on MRI, think DAVF and order a spinal angiogram. And that's a wrap for today's episode of NeuroClarity. We covered how to read T1, T2, and STIR spinal MRI, and we saw the clinical clues and radiological signs of spinal DAVF. We learned why early recognition can be a difference between walking and permanent disability. And until next time, stay curious, stay clear, and keep learning. Do you have more spinal cases you would like us to break down? You can send us an email on vixfornowori@gmail.com. You could leave your suggestion in the comment section, or you could follow us on Twitter on NeuroClarityP. Here at NeuroClarity, we make the brain make sense. Bye for now.